Hello everyone. We will just give people another few minutes to join. We're just going to give everyone maybe a couple more minutes to join. I don't know if people know about this sessions, but seems like hi, we're just waiting to see if we're gonna get a bit more people joining the session.
So I've just from the other session. I think they're waiting till like 1:10 to start. So just to give people time to like get into the rooms.
Okay, just because if the main stage is already started, then people might not know about the breakout sessions.
Sorry, no one's starting on the main page. I think
Perfect.
probably
Okay.
thought she was on the main page, but we've directed her to
Okay.
the
All right. Perfect. Yeah. Okay. I think once we have maybe 5, we can get started. Okay. I think we've got a bit more people. I think I'll start just because I have a number of exercises in the room that I would want people to do. Okay. And also the fact that it's a small group, I guess we will have a bit more time or opportunity for discussion. What I will do is I'm going to invite everybody to stage, which means you'll be able to speak. You don't have to turn your camera on. You can only turn. You don't have to again turn your camera or microphone on, but it would make it easier if you want to speak or ask questions or anything from of that sort. So again, don't feel like any pressure. I'm not going to ask you to do anything. It just helps people to be able to communicate better. So what I'll do is I'm going to share my screen. Once I share my screen, it will be very difficult for me to see who is messaging and if there are any questions. So Tammy will be my eyes on the chat. The plan that I have for this workshop is we will go through the different steps of getting an audit done, and we will go through certain steps. We have 2 exercises planned for everyone. We can do these as individual exercises, but it could also be done in groups, and we will take you through the stages of conducting an audit. So can someone just let me know if you guys can see the presentation?
Yes, we can.
All right, perfect. So it'll be myself and Tammy who will take you through this workshop. We're going to talk about clinical audits, and we're going to talk about quality improvement projects, the differences between them, and which situations are best for which of the two. So the workshop will have about 2 of these questionnaires, a pre-session questionnaire and a post-session questionnaire. They are quite important to fill out, and the importance of that will come clear towards the end of the session. I'll take you through why that's important. So if you just use the QR code and try and do that, it's very quick. It should take about a minute. So I'm going to set a timer for about 90 seconds. And the reason it's going to be short, so it will have one identifier question. You can write your first name, your last name. You can use anything that will help me identify you, but make sure you remember it because I'm going to ask you to use it again. And there are 9 close-ended questions. I've set a timer, and then I'll give you guys time to quickly finish that. It really is important for you guys to try and do this. And again, like I said, I'll bring that, the importance of that towards the end. Okay, 30 more seconds. Okay, 10 seconds.
Sorry, but I cannot open the QR code. It says it has been deactivated for some reason.
Okay,
Yeah, facing the same problem here.
You guys are having the same. That's fine. What we'll do is we'll continue. And when you guys are doing your first exercise, I will try and update the QR code. Okay?
Okay, great.
So, like I said, in this workshop, we're going to talk a little bit very briefly about what clinical governance is. Actually, if you just bear with me a second, I'm just going to stop sharing for a minute. I will continue to speak, but I'll just share the link while we do this. I think it will just be a little bit easier if we do it prior. The reason why we'll start talking about clinical governance is just to put things in context. Clinical audits and quality improvement projects are all part of a clinical governance framework. So I'll start by using that. So can you guys tell me if this link is now working? It will just make it a lot less biased if you're able to fill in the form before. Just let me know if you can access it.
Yes.
All right, perfect. All right, so I'll just do another minute, and then I'll go back to sharing my screen. Okay, about 40 seconds. Okay, 20 seconds. All right, so this, like I said, we'll talk a little bit about clinical governance, what clinical audits are, a little bit about the difference between what a clinical audit is, what a quality improvement is, and research, and we'll do some activities. There are 3 activities here, but I think we'll merge the second and third, and then we'll just kind of close. The big picture of quality improvements generally is that, especially in healthcare, is that there's a big gap between what we know and what we practice. So in England and Wales, 1 in every 5 deaths is avoidable. And by that, we mean exactly the knowledge that we have, the resources that we have, that death could have been preventable if we just did what we already know. But what happens is sometimes there are a lot of different factors that come into play that makes us do care or provide care that is not the best that we could provide at that point. And this gap is where a lot of the audits and quality improvement projects aim to address. The graph on the screen here, scale is just to provide just a kind of a graphic way. There is our current performance, but we have the potential to improve and do better. And with a lot of the quality improvement projects, the idea is we want to give our patients the best care provided, and we want to get the best from our staff. And this is helpful because it allows us to improve health and well-being of our patients, minimize harm to them. We will have a well-trained workforce. Our environment of work will be safe and supportive, and we want to get sufficient resources to be able to get the best from our patient and the best of our staff. This all falls in the context of clinical governance. This is an important question that's often asked in a lot of specialty recruitment interviews. What is clinical governance? And the definition is quite wordy, but if you remember 4 key points, you'll be able to explain the concept very well. So the idea is we want to provide high standard of care, and we want to continue to improve on these standards. And to make sure that NHS organizations do this, we have to make them accountable to the public and to basically to the public. And then we want to emphasize that to get all of these improvements, we need to focus on the NHS environment rather than individuals. And once you understand that, again, this is a general thing. We want NHS organizations, we want to have a good and supportive environment. And the reason we want to do this is this allows us to give our patients the best care, and we will continue to improve on this care. And just going back, the idea is we will be able to bridge this gap. Of course, patients dying, this is inevitable in a lot of cases, but we don't want to have death that could be prevented. There are 7 pillars of clinical governance. PIRATES is the most common acronym used, but there are a lot of others. And they basically, I'm not going to go through them just because of time, but the idea is we want to start with patient and public involvement. We want to prioritize what matters to patients, and that would be an important thing in the philosophy of our hospitals, but also in the GMC. It's always about make the care of your patient your first concern. So you really prioritize what's important to patient. You want to minimize risk to patients in a clinical environment. And these are things like medication errors, infection control. You also want to make sure that you're auditing the care you're providing and you're continuing to improve that. You want to train your doctors or your healthcare providers so that they're continuously updating their knowledge and adhering to the best evidence. And when there are knowledge gaps where we don't know what is the best thing, you want to do research, you want to continue to improve in that. And you also want to manage your staff, because at the end of the day, the staff are the ones who are providing this care. So why should we be interested in audits? It's part of your duties and responsibilities as a doctor. You want to provide safe care to your patients and good quality care, and audits are an integral part of this. But also, when you continue to do audits, when you continue to provide the best care for your patients, then they will have ultimately better outcomes. Doctors get to practice better medicine, they get to practice evidence-based care, they get to comply with regulatory standards and reduce error as a result. So they have better practice in general. And for the NHS, we get better outcomes, and we also are a lot more efficient in using our resources. And another thing that is, and I hope you can appreciate why, is because audits and quality improvements are very important for day-to-day practice. They play a big part in portfolios and for your ARCP requirements, because within the NHS, we want our doctors to really be able to engage in these activities. There are so many different activities for quality improvements. Clinical audits and quality improvements, which are 1 and 2 in this graph, are the most important ones. And these are the ones that we'll talk about quickly in this workshop. So an audit is basically a an established quality improvement and assurance techniques. And what it does, it allows us to measure current care against an agreed best practice. And this is a standard. It's high quality audits is an ongoing cyclical process where substandard care is rectified by implementing small changes over time. So basically, when we're talking about an audit, we're talking about a clear standard. So this standard could come from research evidence, could come from expert consensus, but we have a specific standard. We say everybody has to adhere to this standard. And when we do the audit, we go back and we see how many people, or are there instances where we did not adhere to the standard. And it's important in an audit to understand why we've not been able to adhere to the standard, because that allows us to then design specific changes that are very specific to these reasons, and this should help us improve over time. People often talk about an audit cycle. An audit cycle is a reasonable target for people to get involved and do, but an audit process is a lot more complex. Not complex, is a lot. So an audit doesn't end in a cycle, but a cycle is a complete section. But usually you want to continue to do an audit over and over and over and over. So it's more of an audit spiral, but individual people can contribute to one cycle in that audit. And the reason why it's more of an audit spiral is because usually the standards are quite ambitious, and small changes, you need a number of small changes for it to change and for people to adhere to the standard. So every audit cycle should, in theory, improve adherence slightly, and you need to go back, understand what happened, and improve on it. And even if you reach high standards, so 100% compliance, for example, you want to ensure that you maintain this, so you continue to audit. There are different types of audits. Audits could be prospective, retrospective, so you could either look at and see if, for example, if certain changes happened in the past, you can go back and see what people have done. And it can be prospective. You can start by assessing, then you can do implement some changes, and then you can audit again. And then the audits could focus on things like the structure of the environment you're in, on processes, on outcomes, and they can also be based on the location, whether this is in a community setting, in a GP setting, or in a hospital setting. I'll speak a little bit about structure versus process versus outcome. So, for example, in an audit, when you're trying to audit some structure, you're looking at consultation rooms, seeing if they're soundproof. You want to see if, you want to maintain patients' confidentiality, so you can do an audit to see how many of the consultation rooms are private, or how many of the consultations happen in soundproof rooms. You can look at, for example, staffing levels. You can look at equipment to see if, for example, the emergency trolley is always the defibrillation trolley is always well stocked. You can also do audit processes like triage, screening, and you can try and audit outcomes such as mortality, morbidity, and things like that. So the idea of an audit is very wide encompassing, and it can look at everything that affects patient care, either directly or anything in the process. So there are a few differences between an audit, a quality improvement project, and a research. With a research, you're aiming to prove something. You have a hypothesis and you want to prove that. You want to produce new knowledge. However, with an audit and a quality improvement, you want to improve current care and you want to improve current practice, but you go about them in different ways. So I've provided a few examples here. A research question would be, in women who have dense breasts, what is the best way that we can screen them for cancer? Should we do a mammography or should we do a mammography and ultrasound? And in this situation, we don't know which is which. So we have to then do a research project to try and collect data and understand which is better. But an audit would say, well, the best practice is we need to scan women using this. And in our audit, we want to measure current practice. Every woman that comes in or every patient coming in to have their breast screened for cancer, are we screening them according to the best evidence? So we're not really producing new general knowledge, but we're trying to understand, are we following current practice? With a quality improvement project, we don't actually have a standard. There isn't a clear best practice, but we're trying to improve what's going on. So let's, for example, say not everybody is able to access the guidance to not everywhere people are following best practice. So what can we do to improve access to this best practice so that people can then follow it? And the questions we're trying to answer are very different. In research, we're looking at what is the best scanning method. In an audit, we're looking at how often do we use the best scanning method. And then in a quality improvement project, we are looking at if we do monthly teaching sessions or if we implement any sort of intervention, does this improve adherence to the guidance regarding the best scanning methods? There is overlap between them because they all really aim to do the same thing. So you could really research outcomes of audit. You can try and research if a new quality improvement project will work in different settings. You can publish audits, you can publish quality improvement projects, and you can also do quality improvement projects to improve how people do audits. So there are a lot of different overlap between them. The audit cycle, as we've kind of explained, you start with a question, you look at a standard. Sometimes you have to do a quick search to identify what standards are there. Excuse me. And if there isn't a clear standard, maybe experts in your hospital, like consultants, can come up with a standard. You collect data, you analyze it, and based on what you identify from the analysis, you can then say, well, if the issue was in people didn't know, then you can try and do workshops. If people kept forgetting things, maybe you can have reminders. If people are very busy, maybe you can do automatic things. So really, depending on the finding of your analysis, you then implement change. You continue to implement change for some time, and then you wait to see if that has had an effect. And the way that you know that is you do the second cycle, you collect the data, you audit it, and you see what's going on. And you can see here it ends in implementing change. And then again, the idea is this continues. We're talking about an audit spiral here. And the idea is we will continue to do this until we meet our standards. But even when we meet our standards, we still want to continue to just make sure that we're continuing to adhere to the standard. So I'll send, I'm just going to stop sharing very quickly now, and I'll send a link with this handout. So this is a handout that I want you guys to quickly have a look at. It is an example of an audit that would be helpful if you guys could try and go through. All right. Can you guys access this link?
Yes, we can.
So in this scenario, you are an FY2 in an A&E. You are assessing compliance to the NICE guidelines regarding CT head scans within 1 hour for patients who have specified criteria. So NICE guidelines have criteria for traumatic head injury, and for certain criteria, if you meet these criteria, then you have to have a CT scan within 1 hour, and that CT scan needs to be reported provisionally within another hour. And so all instructions are provided in the hand sheet. Initially, I thought we could do this in group, but just ignore that instruction. What we will do is you can try and do this individually. Try and answer any like these questions, and afterwards, if anybody has would like to share their answer, then they can turn on their microphone to answer that. What I will do is I will set 5 minutes and let you guys crack on with the questions. Three minutes left.
Two more minutes.
Okay, time's up. Does anyone want to share some of their thoughts or their answers to the questions?
Yes, I can share.
Thank you.
So the first question was, what information do you want to collect in order to assess local practice? I think first I would like to assess the knowledge of ER doctor of the criteria when to order CT. So I think this is one of the things. Also, I think I need to go to the hospital records to check, the CTs that are available, if they're according to the guidelines.
Yeah.
Where can this information be found? It's more of emergency and radiology department. The challenges, I'm applying this. If I want to do this in my country, Sudan, I would think the challenges would be to have access to the hospital records.
I see.
Because, the documentation is not that great. But I cannot really relate to the NHS, what kind of challenges I might face there.
That's fine. We'll talk a bit about what you could do within an NHS environment. Thank you, Elaf.
Thank you.
Does anyone have anything to add? Okay, good. I'll just go back to sharing my screen. Can you guys see the screen now? Yeah?
Not yet, no.
No? Oh, there we go. Okay.
Yeah.
What about now?
Yeah, we can see
Okay,
it now.
perfect. So really it's a good start is half the battle with an audit, because with an audit you want to go through patient's record, look at a lot of different information, collect as much data as possible. So before you start, it's really important that you identify what data you want to collect. And the reason why you want to identify this data is you don't want to be halfway through the audit and realize you've missed critical information, because then you have to go back and redo it again. And that takes a lot of time. So one way you could go about it is you need to look at the targets that you want to meet. And then for each of these targets from your standard, you want to consider what information that you need to get that will allow you to understand the compliance of our current practice. And if possible, you want any information that would help you understand why there are gaps. So for example, Elaf, you mentioned you want to know if the doctors actually know of these NICE guidelines. So that would be really important information to know in general, because it would allow you to understand if there are gaps then, because potentially they don't know. You also want to collect identifiers of patients. You want to get information about them. You want to be able to know their age, their gender, maybe their ethnicity, because if you are doing a large audit, you want to see if the findings vary based on these characteristics. In one of the audits the oral presentations, the presenter spoke about how a lot of the chest x-rays should be PA, but many of them were AP, because a lot of them were in older patients who might go down to the x-ray in a bed. So collecting age information will allow it to be able to give us that insight. Also what their complaint was, the time they were admitted. You want to also know the time that the data was collected, and you want it to be as concise as possible, but to cover as much of this information. So you don't want to collect data that are not necessarily important. And you want to make it easy. Some people use Excel sheets, but I find using Google Forms a lot easier, because you keep everything in the same place. You're less likely to make mistakes and enter things in the wrong cell. And you need to know the data sources for what you need to do that. you need from where you need to get this information. You could look at patient's note if they're electronic or if they're paper forms. You also want to be able to access PACS, which is quite universal actually. It's used in different parts of the UK and across the world, and that would allow you to know when the scan happened, what kind of investigations were done. There are a lot of potential challenges that you can get. You can have really poor documentation. So you want to know, for example, what time the risk factor was identified, but sometimes this is not really documented. In emergency departments, patients are sometimes seen by doctors, clerked, have their investigations done, and then the doctors would document. So the times of documentation might not be reflective of when the risk factor was identified. Doctors might not necessarily document all relevant information. For example, if they spoke to the radiologist and had their CT scan vetted, they might not necessarily document that very clearly. And then a lot of these targets are quite aspirational, so 100% compliance. In a lot of times, the standards are 100%, and the reason they are 100%, even though we know 100% is not always achievable, is because we want to encourage people to continue to want to do best practice. The work is never done, so people want to we want to encourage continuous improvement. We want to encourage doctors to problem solve. So if we're always finding that adherence is 85, 85, 85, then those who are doing the job would think about, oh, maybe we can change this, maybe we can change that. And again, it encourages accountability. And if you think about this again, this is exactly what clinical governance is all about. We want to give our patients the best care, and that's why our standards are 100%. They're very aspirational because we want to continue to aim for that 100%. So for the next exercise, you have had the results of this audit. You've got the data collected, and then I want you to assess whether or not the audit criteria has been met. Again, I'll send another handout sheet, and I want you to try and answer whether or not the criteria has been met, and then the percentages, and think about what reasons might have affected this. I know we don't have a lot of time with 10 minutes, but what I wanted to try and get to it as much of it as you can. So I'll just stop sharing, and then I'll send you guys the link. So let me know if you can access this. I'll set a timer for 10 minutes.
Yes, we can.
All right, perfect. So just try and go through as much of the worksheet as you can.
5 more minutes.
Oh, I just noticed some people wanted share access. Just because everybody's looking at the same one, if people can like all edit on it, it might be a bit confusing. That's why it's just view only. But maybe you can download it.
Three minutes more.
Okay, if we've got about a minute left, but if everybody's done, maybe we can come back. Do you guys want to share the answers to the question in terms of whether the criteria was met and if you've managed to calculate some of the percentages?
Should I answer?
Yes, please.
So, according to me, for the first one, the criteria 60% met it.
Yeah.
For the second one, 70%. And then for the third one, I believe that 100% of them clearly documented the indications.
Okay. What about other people? Did everyone else get the same percentages? Okay, I'm gonna share my screen. So in this situation, let me share my actual my answers. So in my situation, I have 1, 2, 3. I have 60% for the first one, and then I have 70% for the second one. But I have 70% for, I have 1, 2, 3. I have 70% for the second one. So it's a little bit different. It doesn't mean that this is the correct one. With these types of audits, let me just, where is my thingy again? Differences are expected. And the reason why differences are expected is because different people interpret things differently. So if we go back to this one, for example, here, I marked this as no because I thought in this situation, the patient has headache, and then the CT is to rule out an intracranial pathology, but they don't necessarily specify why. But in the guidance, it says that if there is suspicion, so where is it? The following criteria if there is a suspicion of an injury. So that you could interpret that as meeting the criteria. You could also interpret it as not. For example, here, this patient had an epileptic seizure and now have a new focal neurology. Someone could interpret this new focal neurology as a post-ictal state. So it might not be clearly communicated that this new focal neurology is because of the head injury. And again, here we want to see if there's a bleed or a skull fracture. So this might not be very clear that we're talking about these criteria. So when different people do different cycles of the audit, for example, it's difficult to interpret the results that there's actually improvement because different people might interpret it differently. And even looking at the same information, people could have very different outcomes. And that's why when people are doing really large audits, like multi-site audits, you would want to have clear standard for what is accepted and what's not accepted, and tiebreakers if people are not very clear. When you're looking at these, if we go back to this, when we're looking at these differences, so we said here there's 60%, there's 70%, and I'm just going with what you mentioned, 100%, which again, we would expect there to be some differences. When you're working in a clinical environment and when you're doing an audit about your own practice, you would have a lot of clear insight as to why this is the case. So when we're looking at situations where the target were not met, sometimes it could be at specific times. So this might be the time when the porters go for lunch. So there might be delays there. It might be around handover time. That's why people are not getting to the scanner in time. This is the morning handover. This is the afternoon handover. So maybe that's why. Also, if it's out of hours, there might be some delays. And that's why when you're working, you're able to really you're able to really identify the issues. And when you're coming out with interventions, in a lot of times people say, well, we would do teaching sessions, but this is the more insights you have from the data, the better interventions that you will have. So instead of saying, well, we would want to do this as a teaching session for in A&E department, you can say, well, we would want to do this as reminders during handovers that people should do X and Y, because that's the time where a lot of people have the most difficulties, or when we're not really meeting our target. So the more information you have, the more insight, the better interventions that you'll be able to have. And this is basically the exercises that we've done. This would be considered, if you've managed to continue to do this, from the beginning to the end, identify the data collected, analyze it. What we've done today is quite sufficient for you to have a good quality audit that you could submit in conferences. I'll just send here what this abstract is like, if people want to have a look. So this is not the abstract. This is for the post questionnaire, but let me just share the abstract with everybody so that you can go through it in details. If you want to, you can copy it or anything. Basically, when you're trying to write it down, what you have to do is, I'm going to quickly go through it, but you have it so that you can go through it in detail. Basically, in your introduction, you want to clearly say that you've audited something, and you want to mention what the standard was. In your methods, you want to explain the data that you've collected, but make sure you clearly mention your targets, because that's what people are able to assess your results on. In your results, make sure you write numbers and percentages. It's not sufficient to say the majority of patients were this or the majority met the target. You need to clearly specify these targets. And then once you've done that, you need to add the insight that you got from this analysis. So in our situation, for example, we noted delays in scanned performance and reported when it was staff break times, when it was shift handovers, when the reporting did not necessarily include clear guidance. And the reason why you want to mention these insights is because you also want to then say, include it in your conclusion. So in your conclusion, you want to have very specific information. So here, for example, you want to streamline the scanning process. So if you find that many people don't mention the indication, you can have a specific CT head request for trauma, and you have to, for example, tick what indication it is or what suspicion it is, and you don't need to mention anything else. You can also include staffing during peak hours or break times. People should not go on break all at the same time. You want to enhance the communication between A&E and the department so that when there's a clear way of saying, oh, this is a 1 hour pathway. So you want to make sure that your intervention are very specific, and this way you would have kind of completed the audit. So I want you to fill in this questionnaire, and this is the last activity that we will do. So it is this link here. I'll send it again. And once you do so, I will just wrap up. We have 4 extra minutes. So I'll give you 1 minute to finish this, and then we'll come back.
Miss, I had a question.
Sorry, did you say you have a question?
Yes.
Oh, okay. We'll take questions in a minute or less.
All right. So I'm just going to share my screen now, and we'll wrap up so that we can go back to the general session.
Sorry, no, there's a question.
Yeah.
Yes. So I wanted to ask, for example, if I want to do an audit,
Yeah.
but there is not a known guideline that I would follow, but I sit, for example, with a bunch of radiologists, and we set a common standard, and then we compare it to those. Is it still considered an audit, or does it need to be a recognized guideline?
No, that would still be an audit. So the standard either comes from research, which would be high quality evidence, but consensus or expert consensus is still considered a good evidence to set a standard. You can start with that, and if you're planning on publishing that or getting that, submitting that as an abstract, just in your methods, you need to say that your standard was set based on expert consensus, and this is the standard. You need to make the standard very clear. but that should be okay, because there's a lot of things in our day-to-day that you wouldn't necessarily have a clear standard for. That doesn't mean you shouldn't try and find similar standards and then say expert consensus and it was similar to this other standard. Hi, Kenny, I see you there. We're just about to wrap up. So I'll just share one last thing, and then that should be the end of the workshop, unless there are other questions. So the last thing is, we talked about audits, but I mentioned that this was also about quality improvement projects. And like I said earlier, that a quality improvement project can be used to improve the conduct of an audit. So this workshop would be considered a quality improvement project. And the idea is we are creating this workshop for doctors to improve their knowledge and skills in conducting audits and quality improvements for the NHS. And like I mentioned, the quality improvement cycle is a plan, do, study, and act. And in this situation, the plan here is us planning the workshop. The do is us doing the workshop at the moment. And to assess the impact of the study is the pre and post questionnaires that you've done. And based on that, we will see if the answers showed any improvement, and that helps us see if there's been an improvement or not. And if there is an improvement, that we want to continue to do this and we want to refine it. So that's a big difference between what a quality improvement project is and what an audit is. With an audit, you start with a standard, but with a quality improvement project, you start with an intervention. And in this situation, like we talked through the abstract for an audit, this would an abstract would be for this quality improvement project. It would be about enhancing doctors' skills and knowledge in doing clinical audits. And I'll send this as well quickly, this information. And that should be it for the audit. Obviously, the result and conclusion part is empty, because it would require you to analysis of the findings. But that is all. Thank you very much.
All right. Let me just before you go. So I've just posted the WhatsApp group. So anyone who sort of like needs the document, who can post it to the research group on the RIGAf WhatsApp research group. So.
Sorry, to do what? The research what?
So I've posted the link to the WhatsApp research group. So anybody who has any outstanding question can ask on the page.
Okay, perfect.
Yeah.
Thank you so much.
Thank you.
All right, bye.
So can we all go back to the main stage? The next session is about to start. Thank you very much. Yeah.
Thank you all. Bye.
Thank you, Noon. Yeah. Bye.